بسم الله الرحمن الرحيم. راح نشرح session على clinical session about the breast, how to examine the breast. Okay. Any examination, when we start to ask you examine the breast, examine the chest, examine the abdomen, or examine the thyroid, usually we start with the general examination of the patient. General examination is very important because something appear in the face related to the breast, such as CA breast, maybe metastasis to the liver, producing jaundice, or patient anemic. So usually we start with the general examination of the patient, see the patient if he is anemic, jaundice, Balair, if he's admitted in the unit or surgical unit with IV fluid, type of IV fluid taken, the patient with Foley's, or the patient with maybe did for him surgical procedure to the breast with a drain. All these subjects we must be mentioned before we starting to examine the breast. After complete the general examination of the patient, usually we go to the examine the breast. First of all, examination of any organ starting with 4 points. First, inspection, then palpation, and then percussion, auscultation. Inspection of the breast, we must expose the breast, both breasts, patient with the sitting position, and start with the normal breast. Patient complaining from any problem in the breast, or come to the uroclinic or breast clinic, complaining from abnormalities of the breast, usually we start him with triple assessment. Triple assessment starting with history and clinical examination. Clinical examination, we start with the inspection, palpation, percussion, auscultation. Before clinical examination, it's important to start with the history. The history is very important to ask the patient and take from him information, gathering information, collecting information from the patient, and about a high percentage of breast abnormalities we can reach to the diagnosis by history. History usually starts with the name. When I ask you, this patient complaining from nipple retraction or nipple discharge, وأقول لك start, take a history from the patient. Usually history start with the name of the patient. Don't forget name of the patient, the age of the patient, resident marital state, and then start with the chief complaint. What are your chief complaint? The aim or goal of our examination of the patient with the breast abnormalities by triple assessment is to early diagnosis of CA breast. Don't forget this point, early diagnosis of the CA breast. Any abnormalities other than CA breast, when we delay in diagnosis, it's not affect on the life of the patient, but when we are delay the diagnosis of the CA breast, this will be effect on the prognosis and the staging of the disease. Okay. What's your chief complaint? We ask the patient, نقول له شنو تشكي؟ هيقول لك الكومبلين الموست common complaint of the patient يجوك with the breast abnormalities هو breast lump, mastalgia, nipple retraction, nipple discharge, or sometime patient complaining from eczematous like lesion اللي هو budget disease. لكن breast mass is important, nipple discharge, recent nipple retraction. These are 3 important complaints of the patient may be related to the CA breast. Chief complaint after that, duration. How much? Especially in the nipple retraction, duration is very important, because the important question when we ask the patient with nipple retraction, we ask him, is it recent or old? If it is recent nipple retraction, be aware that may be a sign of the CA breast. But if old is old, that means maybe congenital nipple retraction. After that, when we proceed with the history, systemic review, and start after systemic review, we start with the important question. We ask the patient, if we have short time, we ask her some question related to or exclude or goes with the malignancy, such as, do you have family history of the CA breast? If previous radiation, previous surgery, do you have marital state, children, take contraceptive pills, hormonal therapy replacement? All these questions related to maybe increase the chance of or increase the incidence patient with the CA breast. And don't forget الage. يعني patient تجيك with breast mass الage 25 years تختلف عن patient with breast mass the age of 50 years. In differential diagnosis, 50 years old with the breast mass, first differential diagnosis we put it CA breast, and then other differential diagnosis. While 25 years old with the breast mass, first differential diagnosis we put what? Fibroadenoma. Okay? So it's important to ask this important question. Patient with hormonal replacement therapy. شنو hormonal replacement therapy? Usually patient after menopause complaining from estrogen progesterone withdrawal. فراح يصير البيشنت complaining from hotness و flushing و depression. Some patient take hormonal replacement therapy with the estrogen. Okay. Important question we ask the patient about the menarche and menopause. Menarche and the menopause, the duration of between the menarche and menopause. If it's prolonged duration, it means that there is high chance to get CA breast. Why? Because there is long time exposure of the breast tissue to the estrogen and the progesterone. And as we know that most of the CA breast is hormonal dependent. What means hormonal dependent? معناته hormonal factor ERPR positive. It means when we are deprivate breast tissue from the estrogen or progesterone will be decrease or delay in distal and the local metastasis of the CA breast. And we know that the aim of treatment of the CA breast is not to cure the patient. Don't forget this point. Not to cure the patient while we are delay and not to prevent, delay the local and the distal metastasis. ليش؟ لأنه the patient with the CA breast we did for her mastectomy, chemotherapy, hormone therapy, and maybe relapse after 10 years, after 15 years, recurrence will be occur. After we take a history from the patient and collect information, then we go to the clinical examination. What means clinical examination? Include by inspection, starting with inspection. General condition of the patient, inspect the general condition of the patient, and then we go to the both breast, inspect both breast, expose both breast, and in sitting position we start with the normal breast. Normal breast, looking to see the contour of the breast, to see if there is any dilated veins in the nipple, areola, and after that we ask the patient to elevate her hand to see if there is any tethering of the skin. And you know what tethering it means there's Cooper's ligament اللي هو hollow viscous filled with the malignant cells. فالليجامنت الالاستيسيتي مالته تروح فلما ترفع البيشنت هير هاند راح يصير تذرنج، لانه فايبرس باند صار هذا الكوبرز ليجامنت، راح يبعج السكن، يطعج السكن اللي جوا من لما ترفع ايديها المريضه، فمعناته انه راح يصير هذا tethering of the skin. And also after elevating the hand we see if any visible axillary swelling, if there is any axillary lymph node metastasis, or patient may have axillary tear. And then go to the abnormal breast to see if the abnormalities, to see the contour of the breast, of affected breast, to see the areola, to see the nipple, if there is any discharge, if there is any retracted nipple, type of the retraction of the nipple, if there is any previous surgery, if there is ipsilateral hand swelling, and after elevating the hand also we see the ipsilateral axillary lymph node, and if there is any dimpling of the skin, or patient may have an blood orange due to the subcutaneous lymphatic obstruction by malignant cells. Then, after inspection, usually we go to the palpation. Palpation also starts with the normal breast. We divide the breast to the 4 quadrants, and by the palm of by your palm examine the parts of the breast: upper medial, upper lateral, lower medial, and lower lateral palpation, and then the central, finally the nipple, and squeeze the nipple to see if there is any nipple discharge, and then examine the ipsilateral axillary lymph node. It's very important to see if there is any palpable axillary lymph node. This would go with the normal, and then go to the other side, the abnormal side. When we start with the palpation, and if we are feeling mass, usually we stop here to give characteristic of that mass. What are the characteristic of mass during examination goes with the malignancy. إذا نشوف الماس هي hard inconsistency, irregular age, attached to the skin, attached to underlying structure, associated with the nipple retraction, associated with the nipple discharge, especially bloody nipple discharge, and if it's associated with ipsilateral axillary lymph node. All these signs you are feel it in the mass goes with the malignancy. What about the auscultation and the percussion in the breast examination? Usually not needed, but it's important to palpation is very important. Okay, this patient اللي جتي عمرها 50 years old complaining from breast mass, history and the clinical examination are more goes with the malignancy. The age of the patient, you family history may have, hormonal replacement may have, nulliparous woman. These signs go, these data more goes with the malignancy. During examination, signs of the mass also more goes with the malignancy. After that, we go to the second step of a triple assessment اللي هو imaging study اللي هو mammography and ultrasound. Ultrasound is important to do ultrasound, easy, starting with the ultrasound. It's easy, harmless. الالتراساوند يرويني الكاركتر of the mass, if it is size of the mass, the mass is cystic or solid, the age of the mass, vascularity of the mass, and also if show if there is any impalpable mass, and axillary also detect if there is any axillary impalpable swelling or lymph node enlargement. Then send for mammography. Mammography اكو character. طبعا mammography usually we use it in patient with more than 40 years old. ما استعملها باليونج ايج فيميل لانه عندي dense fibrous tissue، فالماموغرافي ما ينفعني، ما يطلع لي. لكن من البيشنت يكون more than 45 years old, less dense breast tissue، يوضح لي breast mass if there is any breast mass والcharacter of the mass. واكو character criteria موجودة بالماموغرافي هي اللي تعطيني hint about this patient have malignancy, such as speculation of بالmammography if there is any microcalcification, if there is any distortion or of the age of the mass. After mammography will breast after ultrasound mammography also maybe give hint this patient are more goes with the malignancy. Then we go to the definitive diagnosis. Be careful that الالتراساوند عند الماموجرافي ما ينطيني 100% يقول لي هاي patient have CIA breast. لا، راح ينطيني كاركتر يقول لي انه more goes with the malignancy. بايراد 1 بايراد 2 نعرف هاي النورمال، بعدين ندي بايراد 3 اللي هو probably benign بس يراد له follow up. بايراد 5 and 6 هاي definitive CIA breast. After that we go to the cytological and histopathological examination. FNAC is important. FNAC هو البيشنت ندز نقول له روح سوي لنا FNAC. FNAC هو باي سرنج يعني نلزم الماس وباي سرنج ندخل multiple introduction in the mass under negative pressure نسحب cells and send for cytological examination. ايش راح ينطيني disadvantage of FNAC؟ راح يقول لي هاي cell malignant ده كارسينوما or lobular carcinoma، لكن ما يقول لي هي invasive or not. هذا الديسادفانتج مال ال FNAC. لكن ينطيني يقول لي يابا هذا duct carcinoma lobular carcinoma or هذا benign fibroadenoma or inflammatory condition. زين. Next is core biopsy. الكور بايوبسي بي ادفانتج وبي ديس ادفانتج. الادفانتج انه هذا يطلع لي type of malignancy and invasive or not، ويطلع لي ايضا الهرمونال receptors condition of the breast whether those hormonal receptor هو ER BR HER2 positive or negative triple negative or triple positive. الكور بايوبسي take a tissue and send for histological examination، بينما ال FNA يدز لي cells في cytological examination. وراح ينطيني بالكور بايوبسي هو invasive or not. Okay. This is triple assessment. بعد ما سويت examination عن هاي البيشنت through triple assessment وشيكت انه هاي البيشنت the CIA breast. Next لازم اشوف the staging of the patient and when was the CIA breast and the distal metastasis and according to the TNM. فراح اسوي له another investigation to the chest يعني CT chest abdomen brain MRI to see the level of oral staging of the patient. زين. patient إذا أقول لك 25 years old female breastfeeding complaining from swelling of the breast 3-day duration. هذا swelling during examination pain وtender وhotness وredness. What's your differential diagnosis? First of all you put breast abscess. فالبريست abscess هي most commonly occur in the young age group in lactating women because of a crack of the nipple by the baby lead to the spread of the bacteria from the mouth of the baby to the breast through the crack in the nipple. فتقول لي انه this is breast abscess. Why breast abscess? Young age, lactating women, and the signs of the mass هي more goes with an inflammation. هي الredness والhotness والpain والtenderness والفيفر impatient fever. Okay, what's next؟ ايش راح اسوي له انه هاي من البريست abscess؟ قبل كنا نسوي drainage، انه اجي افتح maximum fluctuated area افتح انسجن عليها وادخل الارتري واسوي evacuation of the pus. بعدين ندخل الفنجر ونسوي damaging of trabeculation لانه هنا الابسس يصير trabeculation خانات او خنادق. nowadays يقول لك انه هذا ما تقدر تسوي له انت يعني تسوي درينج وترد مره ثانيه يصير ريكرنت وتسوي درينج وتسوي ريكرنت وتسوي درينج. ف it's better to do aspiration by wide gauge needle multiple aspiration and send for culture and sensitivity covered with the broad antibiotic بعدين يجيني الculture sensitivity. If it's recurrent يعني failed to do or to heal the patient by repeated aspiration ديك الساعة نروح نسوي لها incision and drainage. زين. patient 25 years old complaining from breast mass duration 2 month duration. تبدي تسأل الفاميلي الهيستوري اوف ذا بيشنت، تاخذ الهيستوري انه تشوف هاي البيشنت هي يانج وما عندها فاميلي هيستوري، ما عندها هرمونال ريبليسمنت، مع بعد يانج. تسوي اكزامينيشن تلقى الماس هذا is well defined mass, mobile, not attached to the skin, not attached to underlying structure, negative, ما عندي palpable axillary lymph node, ويانج age group. You put in your mind this patient in main differential diagnosis first of all اخلي الفايبرودينوما. اذا اريد اتاكد to be sure انه ادي الالترا ساوند راح يقول لي يابا انه هاي البيشنت هي well defined mass, age clear، ما عندي vascularity، freely mobile. بس ما ادزها ماموجرافي هاي البيشنت لان ما ينفعني الماموجرافي لانه عندها دنس فايبرس تيشو. اريد اتاكد بعد اكثر ادزها اف ان اي راح يقول لي فايبرودينوما. What next? Fibroadenoma usually is the self-limiting disease. It is better to not do operation لأنه هاي recurrence يصير بها high recurrence maybe bilateral. لكن يمتى تسوي له عملية؟ لما البيشنت لما increase in size، لما تسوي painful patient complaining ويقول لك دكتور before the mens I have severe pain in the mass, after the menstruation will be relieved, I want to remove it. فif it's large، if the patient إذا أكل any suspicious in diagnosis and if there is any patient complaining or patient wish، هاي الساينز هي اللي نسوي بيها removing of fibroadenoma. Okay. Patient complaining from nipple retraction. Nipple retraction, we have two type of nipple retraction. إما circumferential nipple retraction or slit-like nipple retraction. ليش ده يصير عندي circumferential؟ طبعا أول شيء first of all لازم أسأل إنه هل هي recent or old. إذا recent هنا أخلي awareness. إذا old patient congenital، يعني مرات يصير congenital دول يجون هم congenital retraction دول ما يحتاجون إنه يعني شلون نقول إنه مساج with the physiotherapy، وإذا ما نفع نسوي simple cosmetic procedure ونسوي everted of the nipple. لكن الريسنت nipple retraction هنا أخلي بالي إنه شنو type of recent nipple retraction اللي صاير عندها، اللي هو slit-like nipple retraction or circumferential. Circumferential nipple retraction usually goes with the malignancy, with the aging طبعا. يعني مو تجيني واحدة عمرها 25 years nipple retraction circumferential أخليها أول شيء إنه stay breast، لكن تعتمد عندي triple assessment. لكن usually بالold age with the nipple retraction circumferential more goes with the malignancy. Slit-like nipple retraction usually